everyone. Welcome to our event, Understanding and Preventing Diabetic Foot Ulcers, a Guide for Patients. Today, we will focus on empowering you, the patient, with essential knowledge and practical strategies to manage your foot health effectively. Diabetic foot ulcers are a common and serious complication of diabetes, often leading to severe outcomes like amputations if not addressed early. However, many of these complications can be prevented with proper education and preventive care. Today, we are here to help you understand what diabetic foot ulcers are, how to recognize the early warning signs, and what steps you can take to prevent them. The primary goal of this event is to equip you with the information you need to manage your foot health effectively. By understanding the risks associated with diabetic foot ulcers and the best practices for prevention, you can significantly reduce your chances of developing these ulcers and avoid the complications that can follow. Whether you are newly diagnosed with diabetes or have been managing the condition for years, the insights shared today will be valuable in helping you maintain healthy feet and prevent serious issues. Throughout today's event, you'll hear from experts in podiatry, nutrition, and diabetes care who will share their knowledge and advice. We will cover a range of topics, starting with an in-depth look at what diabetic foot ulcers are and how they develop. Then we'll move into discussing practical strategies for preventing these ulcers through diet, lifestyle changes, and proper foot care. Finally, we will provide tips on engaging more effectively with your healthcare providers, ensuring that you receive the best care and support for your foot health. By the end of today's session, we hope that you will feel more comfortable and confident in your ability to take control of your own foot health. You will leave with practical tips and strategies that you can implement immediately, as well as a deeper understanding of how to work with your healthcare team to prevent and manage diabetic foot ulcers. Thank you for joining us, and we hope you find today's program both informative and empowering. All right, everyone, welcome. Thank you so much for joining us today. We are going to get started with the first segment. So in this segment, Dr. Johnson will explain what diabetic foot ulcers are and why they pose such a significant risk for individuals living with diabetes. He will then guide patients through the early signs and symptoms to watch for, as well as the importance of daily foot inspections. By the end of this segment, we hope that you all will gain a clear understanding of how to recognize diabetic foot ulcers early and how to take the necessary steps to prevent their progression, which can reduce the risk of serious complications in the future. So thank you so much, Dr. Johnson, for joining us today.
Thank you. Glad to be here.
Awesome. So let's just jump right into it. So can you explain what diabetic foot ulcers are and why they are such a significant concern for people with diabetes?
Yes, I have no problem answering that. So diabetic foot ulceration is usually associated with a diagnosis called diabetic neuropathy, which we'll probably get in later in the segment. But essentially what goes on with patients with diabetes, typically unmanaged diabetes, is they typically have developed diabetic neuropathy at a certain interval of time. Honestly, I've seen it onset earlier and earlier now that I've been practicing, but we can go into that later too. But essentially what happens is with this diabetic neuropathy diagnosis, the patients can no longer have the sensation to their feet. Sometimes it's total loss of sensation. Sometimes it's different variations, but typically we'll call it diminished or absent sensation when we're talking to patients. And what happens is so that they don't have that sensation, typically what happens is you have this repetitive trauma, or even sometimes you can have an acute trauma to the feet or certain shoes that you're wearing, certain activities, certain jobs that you do, and you keep getting this pressure to your feet, typically on the bottom of your feet for these patients, and they actually develop what they're called pre-ulcerative lesions, sometimes something known as a callus, and then that callus will eventually turn into what we call a diabetic ulceration if they don't, or a diabetic foot ulcer, if they don't get it addressed by a foot specialist or a wound care specialist, or even just a podiatrist or your family medicine or internal medicine doctors. And so what happens is that you end up with this diabetic foot ulceration, which is this opening wound in your foot. And if it progressively gets worse, it can cause other infections or bone infections get into your blood. And we can also probably get more into that into the segment too. But essentially, to summarize, a diabetic foot ulceration is basically a hole in the bottom of the foot, or sometimes it can be other aspects of the foot, but typically it's on the bottom, what we call the plantar surface of the foot. And it can lead to a detrimental infection and even loss of limb or life if not properly addressed.
Yeah, and you mentioned neuropathy and you mentioned how it's that absence of feeling. So if people with diabetes can't feel it, how can they identify it in themselves?
That's a good question, and it's one of the biggest challenges. And luckily, there is technology being developed that are actually out there, so patients can actually put their feet on a mat to check the different pressures. But let's say, really it's not that readily available, and it is a challenge to get. So we'll do something more practical. Typically, what I tell patients to do is buy, typically from an online retailer, a mirror that you can actually use to see your feet and look at it daily. Or otherwise, you'll have a caregiver or a loved one check your feet for you daily as well, because it is kind of hard. I mean, I'm 35 and and I'm 35 nibble and I still can't get it. Typically, our patients are a little bit older that have this diabetic neuropathy, diagnosis. And what happens is it's really hard for you to even see your feet. So I definitely recommend getting a mirror. There is even I've seen people use selfie sticks, things like that, to try to get to look at their feet, especially if they don't have anyone else to look at it. But typically, that's what I recommend. And of course, interval checks with your physician, typically podiatrists like myself, don't mind seeing you in the office, every 2 to 3 months, especially if you're not high risk. And if you're higher risk, I don't mind seeing the patients every month or whatever that's needed. So also you have those, the healthcare providers taking care of you and watching your feet as well for any issues.
Thank you. And you mentioned neuropathy as one of the early signs and symptoms, and you went into it a little bit about some of the other ones. But what are some of those other early signs and symptoms of that patients should monitor or look out for to know that there's an issue?
Yeah, so other than also, the diagnosis of neuropathy itself, I'll get into, the other aspects of it, but, get for diagnosis of neuropathy itself or diabetic neuropathy, because there's other ways to get neuropathy. I mean, you can get it from chemotherapy drugs. You can get it from idiopathic reasons that we just don't know of, those reasons, but we'll specifically focus on diabetic neuropathy. So, you definitely, once you actually get that diagnosis, it usually starts off as like a burning sensation, then it progresses to that complete absence of sensation that's present there. And so that's the one neuropathy, nerve way or neurological way of noticing changes in your feet. But then you have your dermatological changes. So like you said, like I mentioned earlier about the pre-ulcerative lesions or the calluses that we prefer, most people call it calluses. Those callus hard tissue that's on the skin, sometimes that can also break down and turn into ulcerations as well. Then you get color changes as well to the skin. Typically, depending on your skin type, you get hyperpigmentation, which is increased darkness of the skin, or hypopigmentation, which is whiteness of the skin as well. So depending on what's going on, and those both can be indications of the dermatological changes. Then you also have vascular changes, which means maybe your blood flow isn't that great if you're a smoker, or if you have this diabetes that went uncontrolled for a while. So then your actual skin temperature changes in your feet, that can also lead into diabetic foot ulcerations or because arterial ulcerations. And I know you guys will have a segment with a vascular specialist discussing those type of ulcers, but that is all kind of related as well. And then of course, musculoskeletal. So if you have a bunion, or we call it hammer toes, so use those terms, those bunions and hammer toes, those rubs on the shoes too, and can cause diabetic foot ulceration. So trying to be cognizant of that and making sure your doctor's aware. Like, oh, I've had this bunion for years, but now I can't even feel my feet, so I'm worried about the shoes that I wear, and that can rub on there and cause some issues too. But those are the big highlights. So the skin, the vascular changes, the neurological changes, and then the musculoskeletal are the foot deformities that we have.
And you mentioned it a bit earlier when you talked about having a caregiver inspect your feet, or having them inspect their feet as well,
Mhm.
themselves, their feet as well. Can you say how often should patients inspect their feet, and what should they be looking for?
Oh,
What does a self-inspection really look like, and what does it consist of?
Yeah, thanks for asking that question. That's a great question. So, definitely I recommend daily foot monitoring. Typically, I have the patients, I tell them to do it in the morning, but depending on how active my patients are, I tell them to do it at night too, because I've had it with patients, come in after work or whatever. The next thing you know, they had a blister that wasn't there or something like that. So there goes one thing you look for is blisters, would feel, blisters that are on the feet. Also, like I mentioned, the calluses, and then of course the nails, making sure those nails are being properly trimmed. and either by a professional or by themselves or with a loved one, because sometimes those ingrown toenails too can turn into diabetic foot ulcerations because those nails will start to dig in. And what I mean by ingrown toenails is nails that just get out of control and they dig into the skin, causing some wounds itself to the toes, and that also can lead to some chronic foot issues or even life-threatening issues, which is kind of scary that a foot toe ingrown toenail can do something like that. But also looking in between the toes as well for holes, in wetness and things like that. So you're looking for moisture, wetness, or any holes or lesions that could let bacteria or fungus take advantage of that area. And typically, like I said, if you're an active patient or active person, sorry, you're going to end up with those wetness because of the socks you're wearing, shoes, if you're in boots, if you're working in those environments, you have to be very cognizant and probably check your feet twice a day if you're pretty active. If you're fairly sedentary, not doing much, I think you're okay with once a day for looking at it. But biggest skin changes is moisture, looking for any changes or any like blisters or eating blood, that's not necessarily should be there. Looking for any like abrasions, we call abrasions or scratches or something that's typically maybe it's the shoe and the person can't feel it, something that you've changed the shoe type, and then looking for any like new openings that's there. And I always tell my patients, my job is to, be there for you. It's not like you're bothering me if you want to get on my schedule for me to look at something. Hopefully it's nothing, because otherwise it could be serious.
Thanks so much. And so along with the inspection, are there other, things that patients or people can do to prevent the development of the ulcers? Is there like some kind of daily foot care routine, something more that they should be doing along with the inspection?
Yes, there's definitely something you can do daily. Definitely making sure your skin is well hydrated. So using moisturizers such as lotions, over-the-counter lotions. Doesn't have to be anything expensive. It could be just the generic lotion, but make sure you're using that probably once or twice a day to keep that skin moisturized and avoiding that lotion in between the toes. Even for patients without diabetes, I try to tell them to avoid that too, because if you have too much moisture between the toes, you also can get easy ulcerations or breakdowns, even in patients that have cessation. I've seen that happen too. But yeah, the biggest thing is try to keep that skin hydrated, making sure you're getting your nails trimmed, whether you're doing it by a healthcare professional or a medical professional, or a loved one is doing it, or even yourself if you can reach it and safely do it, and don't dig into the corners of the nails. And then I think that's the biggest thing. And so, make sure you're using wick socks. So making sure you use socks that are wick, moisture wicking socks. And proper shoe size. And so also as we age too, our feet tend to get wider. So making sure you're getting your shoes properly fitted every couple of years as well. I mean, even as I've aged in my 30s, my foot has gotten wider, which is interesting, but it just happens, especially women after childbirth. Sometimes too, your feet will get a little bit wider as well. So that all changes. So you have to make sure you get those checked because you may be wearing shoes that are too small, which can also cause issues.
And you mentioned maintenance. Do you recommend folks who are at risk for these ulcerations to do simple things like the toenail maintenance yourself? You mentioned, not digging too deeply. So do you prefer for people to do it themselves or have someone like a caregiver, someone to do that maintenance for them?
Yeah, that's a good question because patients will come in and say, would ask me that exact same question. So it depends on, we do have we call risk stratification or severity. So it depends on how much sensation the patient has. So if you may have just diabetes and you may not have neuropathy, which is awesome, or you may not have severe neuropathy. So you can definitely have those individuals still trim their own toenails. But once you start to get to the moderate and severe symptoms, you definitely want to have a healthcare professional or a loved one do it with a clean instrumentation, because sometimes they just won't be able to fill those certain areas that others can. So yeah, if you're in a low risk and you have your A1C intact and you following up with your endocrinologist and your diabetes is under control, definitely have no problem with you trimming your own toenails, because I think you'll be able to identify if something's going wrong or if you clipped it by mistake, and you won't be high risk of infection because the A1C is under control. But otherwise, those individuals that A1C is out of control, or they already have an A1C that's in control and they have diabetic neuropathy, definitely want to have a healthcare professional doing it, because that can lead to issues really quickly. And we use steroid instrumentations in our practice in case even if we make a mistake nicking or something.
Makes sense. So, if someone is doing an inspection and they notice a potential ulcer or a abnormality on their foot, what now? What should they do after they think they have something of concern?
Yeah, so typically if they don't, we usually tell them to try to reach out to the primary care docs. But sometimes even primary care docs maybe be backed up with appointments themselves. So even they may not be able to evaluate them. So I definitely would recommend seeing a local podiatrist or even a wound care doctor. Sometimes getting into wound care, if you don't may not have an actual wound, may be tough too, because then they may feel like, oh, you don't have a chronic wound while you're at the wound care center. But typically I'll say reach out to your local podiatrist. We gladly see you and take care of it, and then also refer you to who needs to be seen, who you need to see afterwards in case there's other things going on, such as vascular issues or dermatological issues as well, and then or even endocrinology issues. We'll refer it out afterwards. But typically, I would say reach out to the primary care doc first. If there's no issues with that, if there is issues with that, go to your local podiatrist. We have no problem seeing patients, and depending on your insurance provider, you don't need a referral. Depending on what's going on. If you have like HMO, then that's different, right?
So you actually kind of segued into my next question. And one of kind of my final questions, but it's a two-part. So if you are an individual living with diabetes, how often should you see a podiatrist? And then also, if you do notice that you have some of those abnormal, I can't speak, abnormality on your foot, how often should you then go back to the podiatrist? So what would you say for individuals that don't have those irregularities and who may just have some?
Yeah, they do. Yeah, so it goes back to that risk stratification that I mentioned earlier. So yeah, if you're low risk, we call it low risk patients, A1C is in check, you still have your sensation, your diabetes is under control. Typically, you can get away with once or twice a year, believe it or not, and usually those individuals do pretty well. Then if you get into a more moderate category, sometimes 3 to 4 times a year. Works out, and then otherwise it becomes every 2 to 3 months for these high risk individuals. Really, my high risk to be, I mean, I think the ADA guidelines may be a little bit different, but for me, it's really almost every month if you're high risk, meaning you had a history of amputation, had a history of diabetes with ulcerations. I usually don't even let them go any more than 4 to 5 weeks because I'm worried, and they're worried as well for future breakdowns because you're at double risk of getting another ulceration once you've had an ulceration due to diabetes. So typically that's my regimen, but I think based on the guidelines, you can get away with 2 to 3 months follow up for these moderate to high risk individuals and patients we consider low risk, meaning they haven't had any any diabetic neuropathy, but they have diabetes. Can get away with once or twice a year.
Thank you so much. So those are kind of all of my official questions. I have one more question, and just to kind of wrap things up here, I would love to know, what else is important? What else should individuals keep in mind as it relates to these diabetic foot ulcerations and what it can mean for their everyday lives? So we'll just
Yep.
leave you a couple minutes to talk about that.
Yeah, so the biggest thing I always tell patients too is especially if you have diabetic neuropathy, I definitely recommend seeing an endocrinologist at least once or twice a year as well. So you mentioned how often see a podiatrist. Definitely, if you've had diabetes with diabetic neuropathy, A1C is been out of control, maybe under control now, definitely recommend endocrinology follow-up. I mean, some of my patients have even heard of the endocrinologist, and they've had diabetes 10, 11 years, 12 years, which is kind of scary to not even know the specialty. So I definitely recommend, at least a conversation or, consultation with the endocrinologist. And then also vascular. So definitely if you've had diabetic neuropathy, even without history of ulcerations, definitely want to have those vascular team involved, whether it's an endovascular surgeon or a proceduralist or a vascular surgeon themselves. You want to at least have a loop so you can know who to reach out to in case you do get an ulceration and you already kind of know that person. Because it's usually their PA or NP, so their provider that you'll meet, but at least you have that in case you need some intervention procedures done in the future, because it's most likely you will if you end up with a diabetic foot ulceration, something like that. So that helps. And then, of course, just seeing your local podiatrist. If you haven't had any issues or even had issues, I think having those conversations as well helps, because then you already have that line of communication and don't feel, because I think there's a sense of sometimes of embarrassment or shame, like, oh, something's going on with my foot. But I mean, this is our jobs, and this is what we're here for. It shouldn't be that way. I hate when patients come in with situations that I can't help them with. Now we have to have a whole different conversation.
Well, thank you so much. You've given us a lot of information to take back and help understand diabetic foot ulcers. So, for everyone, I just want to appreciate you for giving us the knowledge. And really, I think when I'm listening to you, it comes down to patients really doing some of the work themselves, being proactive and not being afraid to ask those questions and get those resources, and going to healthcare professionals like yourself with any worries and concerns, because as you mentioned, that's what you're there for. You're there to help. So really do appreciate you taking the time today, Dr. Johnson, to kind of break this down for us, and really do appreciate everything you're doing.
No problem. Thanks for having me. Like I said, we're here to support the patients and make sure they get the best care that's needed. And that's nationwide, worldwide.
Thank you so much. Welcome back. Thank you so much for joining us again today. And I think we're just going to continue on with the event. So in this segment, we will really dive into lifestyle and nutritional factors that play a crucial role in preventing diabetic foot ulcers. So today's speaker, Ms. Summer Wido, will discuss how diet, exercise, and overall lifestyle choices can significantly impact foot health. So this segment will also emphasize the importance of patient education and self-empowerment in managing diabetes effectively. We really hope the audience, you all, will leave with actionable tips on how to incorporate healthy habits into your daily lives and empower you to take control of your own foot health and prevent diabetic foot ulcers. So with that, thank you so much, Summer, for being here today.
Thanks for having me.
Awesome. So let's just jump right into it. So the first question is just, what is the role of blood sugar management in avoiding diabetes-related foot issues?
Oh, that's a great question. It is very important. It's the number one thing that anybody with diabetes can do to help reduce their risk or completely prevent diabetes-related foot ulcers or any kind of injury to their lower extremities. It's real important to understand that somebody with diabetes is at a significant risk for developing any kind of foot infection. And it can happen from the simplest, most common injuries, things you don't even think of, or just from simple everyday life. About 12% of people with diabetes will develop a diabetes-related foot ulcer during their lifetime. And the CDC has some recent statistics that in 2016, 4.9 there are 4.9 lower extremity amputations. So that's your legs below the knee, per 1,000 adults. So that's almost 5 people out of every 1,000 that had some kind of amputation, whether it's a toe, a foot, or their leg either below or above the knee, that's significant. And a lot of those, if not all, can be prevented. Also, 19 to 53% of diabetes patients with a lower extremity amputation end up with a second amputation on the opposite leg within 5 years of the initial amputation. So even if somebody with diabetes has already had an amputation, this is still important because you probably still have parts of your other extremity, and we want to preserve that as much as possible. And blood glucose optimization is the best way to do that. So getting those blood sugars in that target range where your provider and you have agreed is a safe place, generally less than 180 for most people is where we want those blood sugars to average, or A1C of 7 or less. That will significantly reduce your risk for peripheral vascular disease, which contributes to lower extremity infections such as foot ulcers.
Thanks so much. Oh, go ahead.
Yeah. No, go ahead.
I was just saying, so what I'm hearing is that it is, it's true that better blood sugar management can, prevent some of these diabetes-related foot complications.
Absolutely. Nothing bad comes from well-managed diabetes. No bad outcomes.
Awesome. So we talked about blood sugar management a little bit, but what other lifestyle changes can individuals make to reduce their risk of developing diabetic foot issues? I know in the previous conversation we talked about with Dr. Johnson, we talked about ulcers and neuropathy or diabetic neuropathy. So what lifestyle changes can patients make to reduce their risk for developing those symptoms?
Well, one place to begin is a healthy diet. So eating a well-balanced diet that's complete with protein and lots of non-starchy vegetables is really big. Minimizing your carbohydrate intake, so that I recommend working with a registered dietitian so that they can give you specific goals and guidelines for your body and your needs, and sticking within those dietary recommendations that's for your own needs is very important. So as much of the non-starchy vegetables like your green beans, your broccoli, cauliflower, summer squashes like zucchini are important. You can eat those to no end, really, and they're very important because they have healthy vitamins and nutrients for your body. Your feet, because they're the furthest from your heart, they tend to get the least amount of oxygen and nutrients. So when you have the elevated blood sugars, it changes the viscosity of your blood, so it's thicker, which makes your heart have to work harder. And your feet tend to not get all those nutrients and the oxygen that they need, which is why maintaining your blood sugar in a healthy range is super important.
And then, so as we're talking about foot health, can you provide any specific recommendations that support foot health for people with diabetes specifically?
Absolutely. So we always recommend that you should not walk around barefoot. In fact, even just socks alone still poses a risk for somebody with diabetes and any kind of infection. We don't want dry, cracked feet. So you, obviously, as in the previous session, you should check your feet daily. But the shoes that you wear are really important. We want hard-soled shoes with some flexibility while you walk. So we don't want them stiff, but they should fit properly so that your feet aren't being squeezed. Any kind of pressure on your feet, or if the shoes are too big so that your feet are moving around even a little bit in the shoe, that friction and the pressure significantly increases the risk for any kind of wound on your feet, whether it's we call them pressure related injuries. And it really only takes a couple days for those to turn into really bad infections that lead to amputations.
Wow. And you mentioned when we were talking about lifestyle changes, you mentioned diet. And what role, I want to talk about physical activity. So what role does physical activity play in maintaining foot health, and how can patients really safely incorporate it into their
Sure.
routine?
Well, let's think about physical activity and exercise as two separate entities. So physical activity, I like to talk about what we do in our daily life. That's part of daily living, getting up and moving. Or if you have limited ability to get up and walk, even what you do while you're seated. So it's just being in motion. And the American Heart Association, along with the American Diabetes Association, all recommend that you aren't sitting stationary for longer than 30 minutes at a time. So that physical activity is so valuable for your blood sugar and your blood pressure. And the effects of that activity is profound, even past the time that you're doing it. So if I get up and I go for a 30-minute walk, that's not only valuable for my blood sugar during that 30 minutes, but up to hours afterwards. So that physical activity is important, but you of course need to work with a physical therapist or your provider to determine what a safe level is. And oftentimes it's just starting off really small and working yourself up to guidelines of like 150 minutes a week of moderate activity. But the physical activity part of it, what you do in your daily life, is really important. And getting up to where you can have a scheduled exercise routine where you're increasing your heart rate to like a moderate level where you can still talk, but you're having to take more breaths in between talking so that that heart rate is sustained for at least 20 to 30 minutes at a time at a higher threshold is very important. It helps to dilate the blood vessels and get everything moving more. And that, again, helps with your blood sugar. It helps with your blood pressure, which decreases your risk of any kind of lower limb amputations.
That's so interesting. You've given us a lot of great information in such a short time here, but I also want to know, how can patients continue to empower themselves through education? You've given some great information and tips now, but how do you how would you say that patients can empower themselves through education to help better manage diabetes and all of these foot complications?
Well, of course, the American Diabetes Association has great resources for everybody, whether they have prediabetes or diabetes of any type. I use that often in my practice and refer a lot of people to the ADA website. I also recommend that you work with a certified diabetes care and education specialist. Insurance companies consider that preventative. So work with your registered dietitian or a registered nurse or a pharmacist that has special training and certification to help support somebody with diabetes in that journey. The more you interact with that team, we find from research that the better people stay engaged in their diabetes, because if we pretend we don't have it, it doesn't go away on its own. The elephant's still in the room, it doesn't leave. But by working with your outpatient team, whether that's your primary care provider, your podiatrist, and your certified diabetes care and education specialist, that's how we find people can really stay engaged in taking control of their diabetes.
Awesome. Thank you so much. And I guess I have just one more question. And we've been through a lot of, we talked about blood sugar management, we talked about lifestyle changes, nutrition, physical activity. So I just want to open up the floor. Is there anything else that you believe that is important for individuals to know as they go along this journey of, managing their diabetes and what that can mean for foot health? But is there anything else that you would like our audience to know?
I would just say it is never too late. If you haven't been doing anything that you know you're supposed to be doing, or anything new that you're learning that you should be doing, it's never too late to start. Every day is a fresh day, and every day that you do something to help take control of your diabetes, it only improves your health. And then I guess the other thing would be that even as uncomfortable as it might be wearing socks in the summertime, our cardiology team is really big on, if you have diabetes, wear socks every day of the year, because that's the best way to help keep your feet warm enough to keep the blood circulating in your feet and to reduce your risk of amputation and foot ulcers.
Well, thank you so much, Summer. Really appreciate you taking the time to talk to us today. Gave us a lot of great information, and we really do appreciate you being here.
Well, thanks for having me.
Of course. Thank you so much. This segment, Dr. Dove here is going to guide patients on how to become active participants in their own health care by equipping them with essential questions to ask their doctors about foot health. This discussion will cover how to effectively communicate your concerns and ensure that foot health is thoroughly addressed during medical appointments. So by the end of this segment, we hope that the audience will feel more comfortable and confident and prepared to advocate for their own foot health, leading to better care and prevention of diabetic foot ulcers. Thank you so much for joining us today, Dr. Dove. I think we can just jump right into the questions, if you don't mind.
Sounds wonderful.
All right. So the first question I have is, what are the most important questions patients should ask their doctors regarding foot health during any regular checkups they're having?
So I think patients respond very well to very direct questions. And you can start overall with, what should my glucose levels be at for diabetic patients? There is an ideal A1C, but for each particular patient, where should they try to live? You should also tell the patient should also ask the doctor, what should I be doing to ensure that I don't have diabetic foot complications, and what should I worry about? So patients will wonder, well, do I need to check my feet every day? How frequently should I check my feet every day? Also, how often should I have a circulatory test? And should I have you look at my feet during every visit that I come in? Those very basic questions need to be addressed when patients are going to the doctor, to make sure they have a laundry list of things they can do on their part to make sure they don't suffer from complications.
Definitely. And then you mentioned asking doctors for if there are tests or things that they can do. So are there any specific tests or examinations that patients can request from their doctors to help monitor their foot health?
I think the most important tests is to assess their sensation. No matter what, if patients, even with well-controlled diabetes, if they have diabetes long enough, they will typically suffer some loss in sensation. So it is really imperative that the podiatrist or the primary care doctor or the nurse practitioner, whoever is seeing that patient regularly, assess their sensation. And there are some very simple tests that can be done. Frequently, we podiatrists will use what's called a Sims-Weinstein monofilament, where we'll assess 10 spots on each foot on the bottom to see if they have enough sensation to register pain. And that's how we can assess the patient's risk for having an ulcer, because they may step on something that they don't feel. Number two, patients do need to have their circulation assessed as well. And depending on the patient, I advise my patients over the age of 50 at least once a year to have what we call non-invasive vascular testing, which is when we do a pressure on the arm, typical blood pressure, and we do something similar at the ankle and sometimes at the thigh. So we have an idea if the patient has no peripheral arterial disease, mild, moderate, or severe peripheral arterial disease. Those are two baseline tests that should be done with some frequency. And if they're not, the patient should ask or demand that they be done regularly.
You mentioned at least once a year. Does that frequency change if someone is suspecting that they're having some foot complications?
Yes. So when we're talking about vascular testing, we like to start with non-invasive. Non-invasive is what it means. We're not sticking anyone with a needle. They're not being injected with dye. They're very simple tests that can be done outpatient in the office. The rule of thumb is if you have a patient who comes in with a new problem or an ulceration on their foot, you should get a new assessment for peripheral vascular disease, because peripheral vascular disease can progress very slowly, but you can have an acute exacerbation where the patient's condition worsens very suddenly. The patient has nothing to lose. We're not harming the patient. And I always tell patients to insist upon a vascular exam if there's any question of an ulcer or worsening in their symptoms.
And you spoke a little bit earlier about the questions that patients can ask their doctors and during regular checkups. But how can patients effectively communicate their concerns about their foot health if they are, having some symptoms or showing some signs for some foot complications? How does that change how the patient should communicate with their provider?
So in an ideal world, patients, when they come in, they should make sure that that appointment is noted as being specifically for a foot concern. What I will frequently have, and I am a foot specialist, I am a podiatrist, the patient will come in for routine palliative care. They've got a wart or a painful callus that needs to be addressed. And they may whisper or, gently tell me as they're leaving, by the way, doctor, I noticed that my foot's a little bit warm or swollen and I don't know what's happening. That's not the right approach. You want to make sure that any concerns they have are addressed primarily and it's a focus. And I always tell patients, if you're very concerned, make a note, and so you have something to remind yourself, and make sure that the doctor is fully engaged when you're talking to them. In this day and age, when we use electronic medical records and we have such a time crunch, a lot of times you don't have the full attention of the provider. But sometimes I advise patients pause, make sure you have eye contact, make sure they're listening and they're hearing what you say so that that problem can be addressed. And also so that provider can sense that you are very much concerned about this. And this is not a minor problem that can wait for another visit.
And I want to ask about many patients come to doctor's visits with a loved one or a relative or someone that is there. Are there any tips that you would give to a caregiver or a friend of the patient who also may have concerns and want to speak up for their loved one?
I am of the school of thought that it takes a village to take care of these patients. Patients can't do it alone. And we're talking about a diabetic patient with neuropathy who perhaps has a history of ulcers or they have pre-ulcerative lesions. You have to assume that they have other illnesses. Most importantly, they may have compromised eyesight as a complication of their diabetes. So if you have this patient who is somewhat immobile, who is not very flexible, who can't get down to look at the bottom of their foot, I always tell the patient, have the family, the caregiver, the wife, the husband, the children, the friends, they can assist greatly in just looking at the patient's feet every day if the patient can't do that. That way we can stave off very simple problems from progressing to severe problems. And we know that time is tissue in diabetic foot problems. You can have a wound on Monday with the right type of bacteria. By Friday, they may have enough tissue loss that necessitates an amputation. So really you want to have group or familial or your circle of friends involved in your care.
Wow. Did not know that it could progress so quickly. So on that, along those lines, so as someone is preparing for a doctor's visit, how should patients prepare for this visit to ensure they get the most out of their consultation? Are there things they should do, or things they should ask for even at the front desk, or what things can patients do to get the most out of their checkup?
There are several things, and I might be a bit old school, but I'm a big proponent of pen and paper or using your smartphone to write down a list of questions when you go, because we know that when patients come to see the podiatrist or their primary care doctor, they are very apprehensive. Especially one of the most anxiety-ridden visits I get is a patient with diabetes, maybe for 5 years or more, who is coming to see me. And I say, well, I'm not really sure why I'm coming. And I look in the record and it's for an initial diabetic foot screening. Well, a lot of these patients are terrified. They assume that I'm going to tell them the worst news possible, that they are destined to lose their legs. And really, the visit is for education and prevention. So when patients come in, I frequently write things out for them. If they don't have a list of questions, I also incorporate my recommendations into their notes. And nowadays, in the age of electronic medical records, they have a reference that they can go back to. But I will say for some of my older patients, they really enjoy coming in with a notepad, and I practice patience and I go through all of their questions with some limit. I only have so much time, but I try to answer the top 5 to 10 questions that they may have so that they have a clear thought of what they need to do. And also, I like to, when patients come in, I like to give them the risk category for them having an ulcer and amputation. But writing things down and also making sure it's incorporated into your electronic medical record is really, really pivotal.
So, and I appreciate all of the advice that you're giving and how you talk about how you treat and care for your patients. And, we appreciate that that level of professionalism and that you give to your patients and helping them feel comfortable. But on the other hand, what advice would you give to a patient who is not feeling like their concerns are being heard or adequately addressed by their healthcare provider? What can they do? What options do they have?
I think that's a really, really good question, really powerful question. And I know from being in practice for years and years, that is a really difficult hurdle to overcome sometimes. Patients based on their age, where they come from, cultural norms, sometimes are very hesitant to change providers or to seek a second opinion, or they may be wanting approval from their doctor. They don't want to make the doctor mad. On the other hand, I strongly, strongly advocate for second opinions. You have to be confident that you are being heard and your care is all of your concerns are being addressed. If there's any concern that the doctor is not listening or they're a bit blasé or you're not satisfied, go get a second opinion. You have one body to take care of. If things go sideways and you're unsatisfied, you can't necessarily go back and rectify things that have not been addressed and you have a bad outcome. So second opinions are really paramount. I know that if I have a patient who I may send to the vascular surgeons and podiatry work very, very closely together. If the patient comes back and it may be a surgeon I've worked with for 20 years that I love, but the patient did not establish a rapport, I will say, go get another opinion. They say, but doctor, I don't want you to be upset, or I don't want this other surgeon to be upset with me. I said, that's okay. You are the primary person in this equation. Go get the second opinion. Go get the third or fourth opinion until you feel comfortable. Not that they're telling you what you want to hear, but that they're listening and trying to address your concerns. And they're explaining what their thought process is as well.
That is great. And I have one more final question. I would love to know, do you have any resources, or are there any websites or things that you believe that folks can go to get more information about diabetic foot ulcers, or what to do at doctor's visits, or how to empower themselves to take greater action in their own healthcare? Are there any resources that you would?
Well, I think the ADA has some pretty powerful, very straightforward, clearly written guidelines, as well as several podiatric organizations, the APMA, and also the ALPS organization as well. So the resources are there, but I would start with the ADA to get you pointed in the right direction, looking for their foot care guidelines, which are published by consensus by some of the top thinkers in our field.
Thank you so much, Dr. Dove. As always, we appreciate you taking the time to talk to us and to help us empower our patients to learn more and take an active role in their healthcare. So we really do appreciate your time today.
Okay, well, thank you for having me. Take care.